Health inequalities. No doubt you know that these exist, that people don't have equal opportunities to lead healthy lives, and that certain groups find it harder to access the care they need. Hello and welcome to MIMS Learning's Clinical Update podcast. In this special episode, we're looking at this tricky issue. Health inequalities are systemic, and as an individual clinician, you might not feel like you're able to make a difference. So in the next 25 minutes or so, we'll be giving you some practical pointers on what you can do in your practice to make your personal contribution to narrowing inequalities, specifically in cancer diagnosis, maternity care, and for transgender patients. There's plenty more education available on this topic as part of our editorial campaign tackling health inequalities. Follow the link in the podcast notes to see a collection of learning modules covering prison healthcare, frailty, the role of language in diabetes, dermatology for skin of colour, and many more. And don't forget that this podcast counts towards your CPD learning as well, and if you'd like to claim a certificate, you can do so on our website. My name's Rhiannon Ashman, and I'm here with my editorial colleagues.
I'm Sangeeta Krishnan.
And I'm Dawn Liz Powell.
And Pat Anderson, who has recorded our interview earlier on this week. Now over to Sangeeta and Dawn for a discussion on the issues faced by transgender patients.
Thanks, Rhiannon. I'd like to talk about this module on transgender healthcare. It's been written by Doctors Amy Tulip and Demi Thompson. Dawn, you read this module. What were your thoughts on it?
I thought it was a very interesting module, but I think before we got on to discussing the module, I think it might be a good idea first to say what we mean by trans, because you hear the word trans a lot and you hear the word cisgender a lot, and I was just wondering if we should just sort of say what they mean.
Absolutely. So to be transgender means you do not identify as the gender you were assigned to at birth. And to be cisgender means you do identify as the gender you were assigned at birth. So a trans woman was assigned male at birth, but now identifies as female, while a trans man was assigned female at birth and now identifies as male.
I know quite a few people who identify as non-binary. What does non-binary mean?
So the term non-binary is someone who may have been assigned female or male at birth, but now does not exclusively identify as either a woman or a man. Statistics suggest that less than 1% of the UK's population is trans, but in reality, this is likely to be an underestimate.
I wonder if it's one of the reasons for the underestimate is because people are worried about saying that they're trans and they worry about any potential abuse they might get, or maybe if they're older, they simply don't have the language to describe how they feel. Anyway, moving on to the module, that has a video in which trans woman Dee Wilson talks about her experience of being trans and accessing healthcare. She does sort of talk about the relationship with being trans and mental illness, and she says being trans is not a mental illness, but being trans can lead to mental illness. I mean, what do you think Dee means by that?
Dee is right. Being trans is not a mental illness. However, it used to be seen as one. At one point, the International Classification of Diseases, the ICD, categorized being transgender as a mental health condition. Can you believe that? The latest ICD, which is ICD-11, has redefined and replaced these outdated diagnostic categories, fortunately, and terms such as transsexualism, for example, have been replaced with more suitable terms like gender incongruence of adulthood. In terms of how being trans can lead to mental illness, among other factors, people who are trans can experience a lot of discrimination. A 2018 survey from the LGBTQ+ charity called Stonewall reported that 2 in 5 trans people had experienced hate crime in the past 12 months. So that's obviously going to have a negative effect on someone's mental health. In fact, the same report found that 67% of trans people were likely to experience depression and 12% even attempted suicide. By contrast, less than 1% of people in the general population attempted suicide in the same time period.
I think those statistics are really disturbing and shocking, but you can sort of see why there's such a high prevalence of mental illness among people who are trans because of the sheer amount of hate they get on social media. And going back to the module and putting it in more in a healthcare context, in the module there's a video in which trans woman Sophie talks about her experiences trying to access the support she needs, and her experience was not good. And unfortunately, I don't think her experience is that unique.
Sadly, no. According to the Stonewall report, it goes on to say that 47% of trans people who want to undergo medical interventions are still waiting to be treated. 16% of trans people have been refused care by medical professionals, and this is because of them being trans. 32% of people have experienced some form of unequal treatment from healthcare staff due to being trans, and a whopping 62% experienced a lack of understanding from healthcare professionals about specific trans health needs.
Yeah, I mean, I think Sophie, that was sort of Sophie was saying that her GP both lacked empathy and understanding. I mean, why in particular was it so bad?
So, unfortunately, in Sophie's case, she was misgendered by her GP, which she said was a very triggering experience for her. In her case, it was deliberate. Her GP knew that she identified as a woman but continued to refer to her as male. Obviously, it's wrong to misgender a person deliberately. In her video, Sophie makes a powerful statement: never assume that you know a person better than they know themselves. Of course, it's possible to accidentally misgender someone, but in which case you would just apologize as soon as you realize this and move on.
Now, on a more positive note, going back to Dee, in her video, she said that she had a good experience when she first talked to her GP about being trans. What do you think made the difference there?
So Dee's GP said, I don't know what to do, but I will find out. And that's exactly what they did. So I think Dee's account just shows the importance of treating someone with respect and kindness, even if you don't know the answers. So I think showing empathy and understanding could help support anyone, including trans people who are especially vulnerable.
Yeah, I mean, it just comes down to respect, isn't it, really? Just respecting the person in front of you.
Yeah, exactly. And sometimes it's just a small gesture like respecting someone's gender pronouns. These things can go a long way in providing support and showing that you understand them and you're with them. And I think it can really help them in the long run. This module is really thought-provoking in that sense, and I feel it can help clinicians reflect on their practice. Thanks for discussing this module with me, Dawn. This has already proven to be very popular with our learners, and I hope those who haven't completed it yet complete the module after they listen to this episode.
Yeah, Sangeeta, I would second what you say. What's great is that I think it covers off some areas of bad practice that we can, that we can learn from, but it also highlights some areas of good practice, like we were talking about Dee's experience. And it's really important, I think, for clinicians to hear the lived experiences of trans people. So as well as these two videos from Sophie and Dee, there are some quotes included from trans men and other people. So I think it's a really valuable module worth your time reading. And the link is in the podcast notes for this episode, so do check it out. Next, we're going to hear from Dr Anthony Cunliffe. He spoke to Pat earlier this week about health inequalities in cancer diagnosis. I'm delighted to have with me today Dr Anthony Cunliffe. Hi, Anthony.
Hi, Pat.
So he's a National Lead Medical Advisor for Macmillan, Joint Clinical Director of the London South East Cancer Alliance, and also works as a GP. And recently he did a talk for MIMS Learning Live Digital on the topic of health inequalities and cancer, which is what we're going to be talking about today. So my first question to you, Anthony, is what is the impact of health inequalities on cancer outcomes?
So we could probably talk all day on that, to be honest, Pat, because unfortunately, the issues faced by people from underrepresented populations tend to have an impact throughout the whole cancer pathway, right from awareness of cancer symptoms, prevention of cancer through lifestyle factors, through to getting diagnosed with cancer and getting diagnosed at an earlier stage, going through experience of care, experience of treatment, treatment variation, through to recovery after cancer treatment, and even through to end of life care. We see the impact of health inequalities throughout that whole pathway. And unfortunately, many of the same underrepresented groups are affected at multiple points on that different pathway. And because of intersectionality, there might be more ways that they're impacted than just through one health inequality. So it's a real challenge. It's a real issue. Fortunately, it's an area that is getting a lot more focus and a lot more attention, which is great. But there is a long way to go.
So in the talk that you gave, specific things that you mentioned included people being diagnosed later or diagnosed as emergencies, and also
less likelihood of getting radical treatment for some groups. I was really interested to hear a bit more about that.
Yeah, so I guess it's all based on the data that we have, and it's really important to say that data is so important for us to understand many issues around cancer, and to understand the impact of cancer on people from different populations. So it's a challenge because unfortunately the data we have, although it's getting better, is definitely nowhere near the detail of data that we need to have to really understand the impact of cancer at the different parts of the pathway on these different underserved populations. But there is areas that we do have good evidence on. So certainly when it comes to earlier diagnosis of cancer, we do know that there are various groups that are more likely to be diagnosed, or it's probably better to say less likely to be diagnosed at an earlier cancer stage. And one of the big areas is people who live in an area of higher deprivation. We know that people are much more likely to be diagnosed at a late stage, and the things that impact of that are myriad in themselves. So understanding of cancer symptoms, so knowing when to present, and to understanding how to get access and to ensure they get urgent access to medical care and assessment, and also to lifestyle factors. We see a lot of lifestyle factors that are much higher in areas of high deprivation, like smoking prevalence and obesity, unfortunately, which makes us as individuals more likely to develop cancer. But the radical treatment issue, absolutely, we see there are various groups that are less likely to be offered radical cancer treatment. Deprivation is a factor there. Older people is a factor there, and ethnic diversity is a factor there. We don't necessarily understand why that is. It might be around self-advocacy, so being less confident with self-advocacy to ask more questions. They might not be given the right information in a format that they understand to make sure that they're truly informed in the decision that they're making with the healthcare professional. But some of it might be perhaps discrimination, which might not be intentional, particularly around older people. Potentially, we know that actually we shouldn't be offering treatment purely based on a chronological age. We should be taking lots of other factors into account, particularly frailty, and we know that frailty can impact on people that aren't elderly as well. But so there might be an unintentional discrimination there, that people of an older age aren't being offered radical treatment that people younger may be, even though they are healthy and well, and at least should be offered the discussion around what the impact that radical treatment might have on them.
Yeah, no, that's really interesting. And it leads into my next question, which was, could you talk about some of the specific drivers of health inequalities? And obviously, perhaps staff training and their unconscious attitudes might come into that, but there must be a lot of other things as well.
Absolutely. And, I can be honest in saying that this is something I've developed more understanding recently, really. I think certainly as a GP in primary care, we might feel that we know the underrepresented groups in the population that we look after. So we might be aware of what maybe the ethnic diversity is, or the deprivation levels are in our population, but we might not quite understand that the drivers that go behind the poorer outcomes for those groups. And I think one of the most important things is that we need to not only know what populations we serve, but the issues that those populations are facing that are impacting on their engagement, experience, and appreciation of healthcare. So I think there are multiple drivers. And again, we could probably talk all day about the drivers, but we've talked about data already. I've been able to highlight that there's a dearth of data around inequalities, although it is getting better, but so much more work needs to be done to ensure we get better data. An example might be people who identify as LGBTQIA+, and we need so much more data on outcomes for those individuals. And obviously a lot of that is based on routinely collected data, and if we're not routinely collecting that data, we're never going to understand the variation in outcomes for groups like that. Even ethnic diversity, we might feel that we're much better at collecting routine ethnicity data, but still, for a lot of data sources, we don't have the level of data that we need. So just data collection, and as GPs in primary care, we have a real responsibility there. We're looking after these people, and we need to make sure that we are collecting that data and coding it appropriately so that people aren't disadvantaged by that data not being collected. Discrimination, I think we can talk about discrimination, and some of it is unintentional, of course, and that might be down to lack of understanding, lack of knowledge of the particular potentially cultural needs of a certain group. So even though it might not be intentional discrimination, it still has a similar impact on the individuals concerned. Certainly people will report experiencing it, certainly older people, potentially people with learning or physical disabilities, LGBTQIA plus individuals, and people from different ethnic backgrounds as well will report that they feel discriminated against, which leads on to another one of the drivers that we could talk about, which is trust. If you feel that you are discriminated against, or you're worried perhaps because somebody has had a bad experience, then your trust in the system, your trust that you are going to be treated equally, your trust that your data is going to be treated fairly, can really have an impact on somebody's willingness and ability to engage with the system.
Yeah, I think that's a very important point, because my understanding is that it's very powerful, isn't it? Your perceived experience of how others in your kind of perhaps your cohort have been treated has an impact on how you anticipate you'll be treated.
Absolutely, Pat. And I don't think it's just perceived perception of how people have been treated, because people will have had bad experiences due to these different drivers, and therefore it's natural to then have concern that you might have a similar experience, which might impact on your willingness to take yourself forward if you're concerned about a symptom, or to then, if you do have a bad experience yourself, to report about that bad experience because you're worried about how that will be addressed. So these issues can just lead to further kind of widening of that inequality gap.
And so in practical terms, what can GPs do if they're interested to try and tackle healthcare inequalities in cancer and beyond? What can they do?
So I think there's lots and lots of things we could do, but we could cover a few of them now. But I think going back to my first point, it's really knowing our populations, but not just presuming we know our populations because, we know the demographics. It's to really try and understand the challenges that the different groups that we serve are facing, whether it comes to lifestyle changes and prevention issues, whether it comes to ability to access primary care, and various groups report more difficulty in accessing primary care. Whether it comes to getting referred to secondary care, we know that from various sources that people with a Black or ethnic diverse background will report having to go to their GP more times before they get referred on an urgent suspected cancer pathway. We don't necessarily know why that is, but the data is there to support that, and now we need to look at why is that happening. So really understanding our populations, I think, is the first thing to do, and we might, most of us, depending on where you work, we might have multiple underrepresented population groups within our practice population, especially if you work in inner city areas, or rurality in itself is a challenge. So really understanding the whole of the population that we look after, engaging with those populations, engaging with those groups. There'll often be advocacy groups for people from different populations within the area that we look after. So reaching out proactively, reaching out to these groups who advocate for people and who will be able to give us the information that we need on why people are facing the challenges that they're facing, and then we can take that information and address it specifically in a targeted way to really make sure we're improving things. And then there are very specific things like, we'll all have groups, patient for our practices, our PCNs, whatever that might be, and making sure that really looking at those groups and thinking, does that group represent the population that we serve? Have we got the appropriate diversity on that population group? Because if we don't, and we're being led by the suggestions and the guidance of groups like that on how to improve our services, we might just be widening inequity rather than addressing inequity. So something as simple as that, really making sure that we have all the information sources in the relevant formats and languages, so that when we need to provide that information to people, we're giving it to them in a format or a language that they can understand. So there are simple things we can do, and especially now with online access to much of this information, there isn't really an excuse to be giving somebody information in a format that they don't understand. We've talked about prevention and awareness. Should we be targeting our higher risk groups when it comes to our prevention work? So rather than just targeting prevention and awareness campaigns at a population level, should we be targeting at specific groups? Because actually the message they may need to receive, or the way they receive that message, might be very different. And then something as simple as coding of data, which we'd mentioned, making sure that we're coding data correctly. An example there would be the gender that people identify with. I know it's complex, and I know we've got specific rules around this, but just making sure that we understand that fully, and making sure that people aren't being discriminated against because of something as simple as that.
Yeah, absolutely. And on the presentation, you mentioned that GPs could contact their local cancer alliance for support.
Absolutely. I think we don't have to do this in ourselves, and the issues that were needing to address in primary care will be needed to address by others. The same issues will be being addressed by other primary care groups in different areas, either close to where we work or maybe farther from where we work. So there are people that we should reach out to for this. Cancer specifically, I would encourage people to identify what the Cancer Alliance is that looks after their population group. So Cancer Alliances are there to support integrated care boards with cancer outcomes and cancer services in that area, and we are there to support primary care, absolutely. And we have a requirement to support primary care networks to achieve the requirements of the directed enhanced services, for example. So identifying who your cancer alliance is and who you need to contact in that cancer alliance. Most of them will have a primary care lead now, like I am in South East London. So you might be able to do that through your ICB cancer lead, potentially, if you've got one, but identifying these people who might be able to simply provide you with all the access you need to the information in a format for people with learning disabilities or different languages, etc. So that's a really great source I would encourage people to seek out. And third sector organizations, I would absolutely say as well, third sector organizations advocate for the people that they serve, and should have a priority for people from underrepresented populations. So again, from a cancer specific point of view, it might be Macmillan Cancer Support. We have lots of resources to support primary care, but lots of other organisations, Cancer Research UK, some of the tumour specific charities like Prostate Cancer UK, will have specific resources for different underserved populations. So reach out to all these organisations to get the information that you need.
Fantastic, thank you. And just quickly before we finish, what is there in terms of good news to give some inspiration? What can improve if you do sort of tackle what you can control within this area?
So I think there are different areas of good news. One, there's a national program called the Targeted Lung Health Checks, which started a few years ago, but the intention is it will be rolled out to become a lung cancer screening program. But essentially, it uses primary care data to identify high-risk people because of smoking history, and then offers them a lung health check, and depending on the outcome of that lung health check, potentially a CT scan. And what we're seeing is a significant number of people being diagnosed with lung cancer at an earlier stage. And these people, the people being diagnosed, do tend to be from higher areas of deprivation. We are seeing some good news there in that we're seeing a reduction in the inequity gap of earlier diagnosis of lung cancer, probably in big part, at least, to this program. Rolling on from that, there's a significant inequity gap in earlier diagnosis of cancer between the different deprivation quintiles. But for the majority of cancers, we are seeing that inequity gap get narrower. Not for all cancers, we are seeing it exacerbated for some cancers, and at this stage we don't quite know why that is. But for many cancers, we are seeing that inequity gap narrow, which obviously is good news.
That's great news. Very encouraging to hear. So let's hope those inequities continue to narrow. Well, thank you very much for joining us today, Anthony. It's been really interesting to talk through this, and Health inequalities is a big focus on MIMS Learning this year, so we'll continue to keep the pressure up and hopefully provide practical tips for GPs on how they can tackle this area. It can feel a bit overwhelming, but there are things you can do that will really make an impact.
Absolutely, and I think in primary care we are. I'm biased, of course, being a GP, but I think we're the linchpin to really drive improvements in health inequalities.
Absolutely.
Welcome back. As we near the end of our show, we'll be leaving you with 3 key points from a learning module on maternal health, with a focus on equity in care for pregnant and postnatal women. Now, maternal death rates in the UK, you might have seen the statistics, are at their highest levels in almost 20 years. A recent series of reports from the Embrace UK confidential inquiries makes for sobering reading. We've selected 3 practical points for you from a module that we published on this. Dawn, what's the first point that you wanted to highlight?
I wanted to highlight that the report says to offer pregnant and breastfeeding people clear information on vaccination. It's well known that people from ethnic minority groups were disproportionately affected by COVID-19, and the pandemic highlighted the vulnerability of pregnant people to infection. This was exacerbated by confusion and vaccine hesitancy among clinicians, pregnant and postpartum people. The authors of the Embrace report emphasise that offering advice and data on vaccination, as well as encouraging pregnant people to get vaccinated against COVID, flu and other infections, is a crucial aspect of good antenatal care.
So our second key point is to consider initiating a multi-agency needs assessment so that those with complex social needs have coordinated care plans. In this report, many of the women who died were socially vulnerable with a history of drug use or mental health problems. However, these women who may need extra support are not always being identified. For example, professionals should inquire about whether a pregnant person has experienced domestic abuse. This should be done at their booking appointment and throughout pregnancy, but in this inquiry, around 30% of women's records did not include this information. The authors of the report advise that a single conversation with a woman is rarely enough to effectively address the significant obstacles that vulnerable women have. Instead, the conversation should be continuous at each point of contact, with awareness of a woman's vulnerabilities.
And our final key point is to ask your pregnant patients about mental health problems and record this in their notes. The Embrace reports found that almost 40% of deaths between 6 weeks and a year after pregnancy could be attributed to mental health problems, with maternal suicide remaining the leading cause of direct deaths. But for 10% of those who died, it was listed as being unknown whether they had previous or pre-existing mental health problems, which would suggest that the information hadn't been collected or recorded by those professionals that were caring for them. So to recap, the 3 learning points that we've got for you today were to offer pregnant and breastfeeding people clear information on vaccination, consider a multi-agency needs assessment for those with complex social needs, and finally, ask your pregnant patients about mental health problems and record this in their notes. Thank you for listening to this episode of the Clinical Update podcast. All the content discussed today is available on the MIMS Learning website. We really hope you'll join us next time, where we'll have an interview with GP Dr Pipin Singh on lipid targets in primary care. Goodbye for now.